But right now we have a special guest, Dr. Marlyn Mayo, and she's going to be talking about managing PBC itch. Let's start from the scratch. Dr. Mayo is a professor internal medicine at University of Texas Southwestern Medical Center, and this session is going to cover the typical features of PBC itch, tips on lessening the itch, current options for medications, and new treatments under development. So thank you for your time.
Thank you very much. The mic is on, right? Oh.
Yep.
So it's a great pleasure to be here. I want to thank the organizers. I know Carol and her team put in a lot of effort to bring this conference to y'all. And if it weren't for the help of the sponsors, we wouldn't be here either. But as you can see by my lovely footwear, I had foot surgery a couple of weeks ago. This is literally my second day out of a cast and my first adventure kind of out and about, so it really, really is a pleasure to be here. As he said, I'm going to be talking about PBC itch. My hope for this session is that if you do have PBC itch, this session will either reassure you that you and your doctor are doing everything possible for your itch, or maybe it will give you some new ideas that you can present to your doctor, or if you don't even have itch, that it will help you to understand what others are going through and prepare you in case you do develop it in the future. So full disclosure is that I'm an investigator for a lot of clinical trials in PBC and also do some scientific advisory work for some of those companies. All the research money is not paid to me, it's paid to the university. But a lot of these companies are trying to develop drugs that are helpful for PBC itch, and so I'm going to do my best to present their clinical trial data to you in a fair and unbiased manner. All right, so the medical term for itching is pruritus, which comes from the Latin verb prurire, and because a lot of people seem to have a hard time figuring out how to pronounce it, I'm giving you a little rebus here. It's purr, like the sound that a cat makes, I, like your eyeball, t, which is the T sound, and then us, which today is the PBCers organization. So put it all together and you get pruritus, okay? If you want to be really fancy, you can add that subtle R in the purr, but it's barely pronounced at all, so it's pruritus. And honestly, most people just leave it out. If you don't even include it, nobody's going to know the difference. So how common is itch in patients with PBC? What do y'all think? Very. Very. You want to tack a number onto that? 95. I'd say 100. 50. Okay. Well, let's take the average of that. 75%. 75% of patients with PBC will experience itch sometime over their disease course, and they might not always have it. If we look back at, for example, the original trials of ursodiol, during the patient session, we had somebody who was involved with those original dosing trials. 60 to 70% of the patients in those trials had itching. 23% of them were actually severe. And a little bit more modern data, this data comes from something called the Target RWE study. This is a study where they collected information, questionnaires from PBC patients all over the US from different kinds of practice environments. So some were from small internal medicine practices, some were from big, liver transplant centers. And this kind of a geographic type study is supposed to take away some of the bias that you see when you just look at a big academic center where people are specifically enrolling in a therapeutic trial. So in that study, they had 211 patients who filled out the questionnaires. The PBC-40 is a question about your lifestyle. Having PBC, you may be familiar with it. And out of that population, 81% reported that they had itch. So 20%, 19% had no itching at all. And if you look at the breakdown, most of that was mild itch, 51%, but a good 30% was moderate or severe. All right, so one of the questions that comes up a lot from patients and even physicians sometimes is, well, I itch, but is it from my PBC? Because other things itch as well, right? Doesn't mean you can't have a skin disorder, or sometimes I'll hear, well, I do itch a little, but my skin is dry, and I think that's what it is. Or I just have a little bit of itching. Isn't that normal just to have some itching? And it's often quite difficult, actually, to sort out whether the itching is from PBC or whether it's from something else. But there are some clues. So itching that comes from liver disease has some typical features. I will say that PBC is not the only liver disease that causes itching. We can see it with hepatitis C. We can see it with alcoholic cirrhosis. We can see it, with a number of liver diseases. But it's really a prominent feature of PBC and of PSC. So the biliary diseases tend to have more itching, and they have it earlier on. The itching will often start out being localized, so just like one little spot here or there. But if it progresses, can just be generalized and involve the entire body. One unique feature about liver itching is that it has a predilection for the palms and the soles of the feet. So I see people nodding their head and going, yep, it does. But that's unique to liver disease. So if you see itching from other skin conditions, those areas are usually spared. So I often use that as a clue to determine whether the itching is from the PBC or not. And you can see some pictures here of some patients with itching and where they have scratched, and the bottoms of the feet is a commonly involved area. So PBC itching should not cause a primary rash. So what I mean by that is a rash that comes up before or at the same time as the itching. You can have skin lesions, and you can see in the illustrations some of these skin lesions, but they're secondary to scratching. So you can get scratches, you can get bumps, you can get red crusted bumps, you can get what they call prurigo nodules, which are these dark, lumps. You can get darkening of the skin. There's a mention on the slide here of butterfly sparing. I don't know if you all know what that is, but there's supposed to be a picture of it in this picture of the back. You can see these linear scars where the person has scratched these lines, but the area in the middle of the back, if this was a female, it would be like kind of where the bra strap is, and then extending up to the shoulders is spared. So it really, if you look at a back, it'll be, scratches up here, scratches down here, and then a clearing in the middle that looks like a butterfly. It really just represents the areas that they can't reach when they're trying to scratch. But it is kind of a characteristic feature to see this butterfly on the back. The itching has a course where it varies, and it's typically worse in the evenings. That is not unique to liver disease itching, but it's a typical feature of chronic liver disease or chronic disease itching. But it's often definitely worse in the evenings. And things that make it worse are usually heat and pressure. I live in Texas, and this is Arizona, so in the summer people get hot and sweaty, and that tends to be when it really gets bad. Or pressure, like pressure from the clothing, tight clothing can exacerbate the itch. There's a very tight connection between the itching and how well you sleep, especially since the itching is worse at night. So studies have shown that 74% of people who have the itching their sleep is disturbed from it. And actually we have a paper coming out very soon that shows a little bit more detail on this very tight correlation between itching and sleep disturbance. And then when the itching is chronic, it starts to mess with your mind. It can cause depression. I see a lot of people who have social isolation. They don't want to go out. They're afraid, that other people are going to think they have some kind of contagious disease if they're scratching or if they have lesions that look like this. And that's how it can really affect the rest of your life. It's important to realize that the itching in this disease is not correlated with the disease stage, okay? So somebody can have bad itching and very early stage disease. Somebody can have very late stage disease and not have itching. If you didn't have itching and then you develop it, it doesn't necessarily mean that your disease has gotten a whole lot worse at that point. There's just no good correlation. The time course varies a lot. It's intermittent, so people will have periods of time where they itch, and then it'll be, thank goodness, sometimes a period of relief, and then it'll get worse. But it does tend to be overall progressive over time. So once the itching starts, it tends not to just completely disappear on its own, unless you're at the very, very end stages of liver disease, okay? So it has this self-extinguishing feature we see almost right before liver transplant, and we do not understand why, but patients will say as they're nearing the need for a liver transplant, now my itching went away. And it's a phenomenon that's well recognized. We don't know how to explain it. All right, so I sent out a question on the app for this conference to see what y'all had to say about what makes your itching better or worse. I got a couple of answers early on. I had to turn my slides in a few days ago, so if you responded after that, I apologize, you're not on here. But things that people say that makes their itching worse are stress. We heard a lot about that today. Heat, which we know also. Clothes, touching. This was sad, just breathing sometimes. Things that make it better are cold shower, standing outside when it's cold. So again, it's this temperature modulation. Ice packs, that's something I'll often recommend to patients if they have an area that's just, the itching just will not stop. This is my favorite, frozen peas. And then somebody said a cool wrap from pbcers.org, and I was not familiar with this. I tried to follow the link and look at it, but I couldn't find it. So, and if you Google cool wrap, all you get is a sandwich from Chick-fil-A. So, so I don't know if that's something that you all sell on the site, or I don't know if any, does it? Okay, perfect.
It looks like this.
Ah, okay, so it's like a ice pack thing. It's like a gel ice pack. It looks like a breast implant. Love it. It's not much of a breast implant, though. All right, so relentless itching is a miserable condition. In fact, historically, this was considered one of the circles of hell in Dante's Inferno. So if you're not familiar with Dante's Inferno, it's a book where people who committed various crimes and treacheries in their life would be forever committed to a particular part of hell where they suffered a particular consequence. And if you look at it like a close-up of the picture down there, I think I have a laser pointer, maybe over here. Yeah, so some people, like these people, are forever condemned to being upside down, right? So the 8th circle of hell, which is down here with all the bugs and the creepy crawlies and the snakes, was the circle of hell with eternal itching. And that was where traitors were sent for the rest of eternity. And then on the right, we'll see if this works. This is a video from one of the pharma companies that is trying to develop a drug in the itch field space. They had this little interactive exhibit that's supposed to show you what it's like to have itching, little bugs crawling all over you. That's me at the liver meetings. All right, so what causes the itch in PBC? I wish I could answer that simply for you, but I can't. It's very complex. You've seen a lot of graphs and pictures of brains today, so I'll try not to overload you too much. On the right, what you see is the itch pathway that's been worked out for skin diseases. So the stimulus starts in the skin and it travels to the spinal cord, and then it travels up the spinal cord to the brain, and it activates specific areas of the brain. It activates the spatial sensory cortex, and that tells you, where you're itching, like your mosquito bite happens to be on your, your left arm. It activates the premotor cortex and the motor cortex, and that is telling your body you're getting ready to scratch that area. And it also activates a lot of these, what we call limbic system. You heard a lot about that from Dr. Swain today in the fatigue talk, which deals with pleasure and reward, anticipating it's going to feel better if you itch, processing the feel that this is noxious, that you don't like this stimulus, and how do you think of and process that that symptom. And I will also say that even the neural connections between the cognitive cortex are important, because if you probably just listening to this lecture, some of you will start to itch, or if people start to talk to you about itching, it will make you start to itch more, and that's a normal neural connection. On the left, you see a long list of chemicals. I'm not going to go through all of them that have been proposed as agents that may be important in causing the itch in PBC. Histamine is the typical agent that causes itching in mosquito bites and poison ivy and atopic dermatitis and many of these other conditions. Every study we have ever done has not shown histamine to be important in this disease. There's no increased levels, it doesn't seem to change at all, and that's why most doctors that you find that specialize in PBC are not very enthusiastic about using antihistamines for this disease. A lot of people will take them anyway, and sometimes they will help, and most doctors will say, well, probably because they're a little bit sedating, so you just kind of feel a little calmer and you can sleep a little bit better, but theoretically should not actually address what's causing the itching. And then there's a long list of other things. If you're a chemist, you'll be interested in all of those. So I'm just going to show you one functional MRI, and thankfully Dr. Swain introduced the whole concept, so I don't have to go through that. This is a study we did with, we haven't published it because it was only 6 patients with PBC itching, and you can't publish a paper with only 6 patients, and they're very expensive to do, so we couldn't do any more. But these images are the combination of all 6 patients together, but the findings were very similar between all 6 of them. And basically the areas in red are the areas of the brain that light up when they're itching, and the areas in blue are the areas that are activated, and the areas of blue are the areas that are deactivated when they're itching. And on the right, you see the list of the areas that are activated. And if some of those names look familiar, like amygdala, orbitofrontal cortex, anterior cingulate, that's because you've heard about them already today. You heard about them in the stress talk, and you also heard about them in the fatigue talk. This is the limbic system that really processes your emotional response and fear and how you're going to deal with this sensation. But what I want to point out about this is that we did not see any activation in the sensory cortex, okay? So that means this is not just a simple sensation, like something on the skin that is making you feel that there, okay? This is what we call a viscerosensory or a visceral feeling. So other visceral that's one that comes from like inside. So other visceral sensations are nausea, dizziness, thirst, right? So if you have somebody who's thirsty, you can, look at their mouth and do all kinds of biopsies and tests, it's going to be normal. Or you can take a pregnant woman who has terrible nausea and vomiting from pregnancy and do all the studies you want on her stomach, and they'll come back normal, all right? So we do all these studies on the skin and PBC, and it's normal, all right? And patients will even sometimes say it feels like the itch is actually even a little bit below the skin. So this is not just simply a skin problem. It's coming to some degree within. Okay, so I'm going to spend the rest of this talk talking about management of the symptoms. All right, and my first slide is called I don't like taking medicine, because I hear that a lot from patients, especially those who have mild itching that don't want to take anything. So what can be done? And I want to stress that none of these have been tested in the classic randomized controlled clinical trial to prove that they are effective. They are just a combination of what we've heard from patients through questionnaires and other kinds of observational studies. And that is to use, loose absorbent clothes to deal, with the heat and to reduce the amount of pressure. Avoid dry skin by using plenty of nice moisturizer. The ones in the tubs, as opposed to the squeeze tubes, are usually the ones that are going to stick around the longest. Avoiding other things that can make itching worse. So, for example, narcotics, any kind of codeine or hydrocodone is going to cause itching on top of that. Another important thing to do is to keep your nails really short, because when you're sleeping, even if you don't know it, you'll scratch the area and cause trauma, and then that gets the whole itch scratch cycle going and can make it worse. As we talked about earlier, you want to try and keep your environment cool but not too dry. With showers, I think it's, I'm a hot shower person. I love taking a hot shower. So I just can't tell people not to do that. But I think it's important at the end of the shower to rinse off with very tepid water, to bring your skin back down to sort of room temperature so that you don't have that flare after the hot shower. And then for times when there's like a specific area that's just driving you nuts, I think ice packs or this little PBC Cool Wrap would be appropriate. You heard a little bit about UV light. I'll talk about that as well, but sun exposure can actually help. And then another thing that people say help can be like a menthol spray or cream. These are like any brand would do, but BioFreeze is one, or you can get these menthol-filled things, which basically produce like a sting or a stimulus that will, almost like scratching, that will cover up sort of the itch. Doesn't last very long, but sometimes it can break a cycle, and at least as opposed to scratching, doesn't tear up your skin. Okay, so dermatologists are quite fond of using UV rays to treat chronic itching in many different chronic itching diseases. It does work on the histamine by inhibiting release of that. It also works on the bile that's accumulated in the liver. It mobilizes bile and for kidney patients, the kidney salts, and pushes them into the urine so that you pee more of them out. So it is kind of helping to rid the body of some of those excess bile acids. There have not been many clinical studies in PBC patients, a very small one from 1980 of 6 patients, showing that it does help, but it takes about a week of doing this, and the effect only lasts a couple of weeks. So if you're doing a light box therapy with a dermatologist, you have to go pretty much every couple of weeks. But if there was ever a reason to say, hey, my doctor said I need to take a vacation and go to a cool sunny place, this is it. It should help. As for medications, unfortunately, ursodiol, the treatment that we use for PBC, doesn't appear to affect the itch one way or another. In this graph, you see kind of all the major ursodiol trials, and the line in the middle represents no effect on itching, and whether placebo or the ursodiol seem to help the itching. You can see the net result in the bottom square there is just square over the line, which means it really had no effect one way or another. I have, however, these are generally 1 to 2 year trials. It is, however, not uncommon. I hear this when patients very first start ursodiol, that those first few weeks, their itching actually might get worse. Again, we don't know why. We think maybe it's kind of the flushing out of some of the bile acids, but that initial exacerbation tends to go away. All right, so our second line treatment for people who don't get an adequate response, particularly with respect to their blood tests, the alkaline phosphatase and the bilirubin, or if they don't tolerate ursodiol, is to treat with obeticholic acid, which we lovingly call OCA. You may know it by its commercial name, which is Ocaliva. And you may or may not be aware that the main potential side effect of that drug is it can actually cause itching, like start itching when you didn't have it before, or if you had itching, make it worse. And this graph shows you the cumulative data from their long-term follow-up study, which I believe was 5 years in duration total. And you can see that over time, 77% of patients developed itching. And if you look at the bottom graph, it kind of shows you over time. Most of those are mild itching, but some are moderate and some are severe. And you'll also see that the increase really happens over the first 1 to 2 years, and then it's fairly stable after that. So we hope that means that if somebody doesn't get itching from this drug after a couple years, they're not going to, but we don't know that for sure. All right, so eventually somebody might say, okay, it's bad enough for me to take something now. And what I have shown for you in the diagram here is the recommendation that the American Association Study for Liver Diseases, the AASLD, gave to doctors in their guidelines in 2009, which is you go through this stepwise approach of medications. You start with a bile acid sequestrant, which is like cholestyramine, brand name Questran or Questran Light, or Cholestipol. If that doesn't work, try rifampin. If that doesn't work, you can try one of these opioid antagonists like naloxone or naltrexone. If that doesn't work, you can try one of the SSRI drugs that have been proven to help itching, such as sertraline or paroxetine. So that order was solely based on the sort of the amount of data that we had and longevity of the data that we had. It wasn't based on one necessarily being better than another. And so the newer guidelines, which were revised in 2018, don't have that step line. They just say you can start with any one of these. That's kind of how I do it in my practice, is we sit down and we talk and we say, okay, we have these 4 options. We lay them out on the table and talk about their effectiveness and their potential side effects and see which one seems to be the best fit. If one is started and it doesn't work that well, or if it works if it doesn't work at all, then we get rid of it and try another one. If it works a little bit, you can try usually increasing the dose. You can stack these and add, more than one medication. Notice that antihistamines are not anywhere in this guideline, but people do use them a lot, primarily for people who have mild itching in the evenings to help them kind of fall asleep. Another drug that's not in the guidelines because it doesn't have good evidence behind it, but anecdotally some doctors will use, is gabapentin or Neurontin. Okay, I'm going to this is a little complicated table, and I'm going to spend some time going through it because this is all of these sort of already available medications we have to treat itching and PBC, how they are given, and kind of what their pluses and minuses are. So at the top we have the bile acid sequestrant cholestyramine. It comes as a powder, and each scoop is 4 grams, and you can take anywhere from 1 to 4 scoops 1 to 4 times a day. This powder is insoluble in water. So I saw someone else on the Huvo app said, this is like, and I've heard this before, this is like beach sand in a glass of water, and it's going to be like that because it will not dissolve completely. That's the way it's made. Potential side effects are that it can cause constipation or bloating. Probably one of the most difficult ones is that it not only binds to bile acids in the body, but it also binds to a lot of other things, a lot of other medications, and so you can't take it with your other medications. It's supposed to be dosed an hour before or 3 to 4 hours after, and if you're taking medications 3 times a day, it's very hard to get 4 doses of this in during a day, and it just becomes kind of a logistical nightmare. For people who don't like the powder, there is a bile acid sequestrant that comes in a tablet form, and that's the Colestipol. And the dosage there is 2 to 16 grams a day, again, 1 to 4 times a day. It's a similar type drug, has the same type of potential side effects. The downside here is that it only comes in 1 gram tablets. So if you're taking 16 grams a day, that's 16 pills a day, and they're not small. They're like the size of large multivitamins. So that's part of the discussion that we have. Would you rather drink some beach sand and water, or would you rather take 16 horse pills a day? Usually the answer is neither, but this is kind of what the options that we have. Next on the list is rifampin. This is actually an anti-tuberculosis drug. And so a lot of times pharmacists don't understand, they're like, do you have TB? Why are you not wearing a mask? But one of the major side effects that it has, or off-target effects, I should say, is that it upregulates production of a bunch of things in the liver that can kind of help get bile acids out of the liver as well. So not only is good for TB, a lot of these drugs you will see have 2 purposes. And that dosage there is 150 to 600, either 1 to 2 times a day, usually very well tolerated. Sometimes you can get, fever, rash, nausea, vomiting. Elevated liver enzymes doesn't happen very often, but it can be dramatic. So we have to watch the liver carefully if we're going to give this. It can make the liver enzymes actually shoot up, and if that happens, then you have to stop it. And it can affect metabolism of some other medicines, so you have to look at your medication list. Your doctor has to review and make sure there's no interactions. Naltrexone, which is the opioid antagonist, 25 to 50 milligrams a day. People who have chronic liver disease typically have naturally high levels of your natural opioids. So people naturally have opioids in their body. That's kind of how you help regulate pain. When you immediately cancel all of those, sometimes the consequence is everything starts to hurt or you don't feel good. Or some people even feel just like if they're used to high levels and then you block that, they'll even feel like a heroin addict who's just is going through withdrawal. So you have to be cautious of the potential side effects there. A lot of doctors don't like to prescribe it because of those potential side effects. And then sertraline, which is a antidepressant, which also has some anti-itch effects, can be given at 75 to 100 milligrams daily. Generally well tolerated, but it can cause some loose stool or some irritability. Mood stability, in my mind, is actually a plus with that, but all right, so moving on. So liver doctors, unfortunately, are not good at addressing itch. So this is a study where we were recruiting patients from waiting rooms of different clinics and asking them about their itch, and then we went and looked at the office notes to see what the doctor said. And in the liver clinic, only 53% of the patients who said they were suffering from itch did the doctor actually put it in their note that they asked about it or did with it. So it's not very good. You can see dermatology was quite good. They were the best, 99%, and the worst was surgeons. Probably not a big surprise there. All right, and on the Huvo app, I said, with respect to my itching, I wish my doctor would, and somebody said, I wish I had doctors that would have validated my itching, even if they couldn't do anything about it. And I think that is so poignant that liver doctors, even if they don't have something to treat, should at least be addressing it. And similarly, liver doctors are not very good at treating itch, unfortunately. This is data from that same Target study where they did questionnaires across the United States and asking patients what they're taking. And you can see the vast majority of patients who had, and these are only patients who had itching. And the dark blue is clinically significant itch, which, if you know, is on the PBC-40 is a 7 out of 15. And then the light blue is mild itch. And the vast majority of patients, even those with clinically significant itch, were not taking anything. If they were taking something, the most common drug was an antihistamine, which is probably the least effective of all the options. And then you can see the other things that were prescribed. So we, unfortunately, are not very good at doing this. Now, some of this may be patient reluctance to take medications, but I can't help but blame the doctors for a lot of this. Okay? All right, so now the exciting part, which I have to hurry up, which is what's new in drug development for PBC itch. And there's two classes of drugs that I want y'all to be aware of that are coming on the horizon. And they are the IBAT drugs and the PPAR drugs. So yeah, go ahead and take a picture of this slide. So those, and they stand for very long words. IBAT is ileal bile acid transporter. PPAR is peroxisome proliferator activated receptor, but that doesn't matter. They're IBATs and PPARs. Okay, so what do the IBAT drugs do? So the bile acids that are made in the liver normally travel down that green tube through the biliary tree into the intestine, where they do their work as a digestive juice and digest the fats. And when they get down to the bottom of the intestine, right before the colon, they get reabsorbed and then through the blood and go back to the liver. And that's how our body reuses the bile acids over and over and over again. It's a very efficient process for digestion, but it also keeps your bile acid levels pretty high. So what the IBAT drugs do is they block the receptor that reuptakes the bile acids. So your bile acid levels fall, and a lot of the excess just gets washed out with your poop. And there is now a good precedent for using these kinds of IBAT inhibitor medications to treat liver itching. There are now 2 different IBAT drugs that have been approved fairly recently to treat liver itch in children. So odevixibat in July of 2021 was approved for progressive familial intrahepatic cholestasis, or PFIC, and in June 2023 was approved for Alagille syndrome. And maralixibat in September 2021 was approved for Alagille's, and in March 2024, just recently, for PFIC. So we have 2 drugs in this class that are now FDA approved for use in children who have similar itching to people with PBC. And that should be reassuring about the safety of these drugs. that we're actually giving them to children at first and even toddlers. And in fact, these drugs are not even, they do their work in the intestinal lining. They don't even get absorbed. So a lot of patients find that reassuring, that these drugs are not getting absorbed and they're not getting processed through the liver like most drugs are. They're simply blocking at the level in the intestine and then just getting pooped out. All right, so this is one of the IBAT inhibitors that's being tested in adults with PBC. These are data from their phase 2 study of linerixibat. On the y-axis is the numerical rating score, so just kind of rating your itch from 0 to 10. And with different doses, how much the itching improves. And you can see there was about, a 2.5, 3 point drop on that scale. And their best results were with the 40 milligrams twice a day, which is the dose that they're currently investigating in their phase 3 trial, which we hope to get the results from soon. Before I leave the IBAT inhibitors, I mentioned how they're very safe because they don't get reabsorbed. The one potential side effect that we do see is due to the fact that bile acids they're toxic little buggers. That's what's damaging your liver in PBC in the first place. They're also irritating to the colon. So as you're flushing these bile acids out your colon, it irritates the colon a little bit. And so the one side effect that we can see is increased number of bowel movements. Some people can get abdominal pain or abdominal cramping. And so we're still working out in these clinical trials kind of what is the best dose to get the maximum efficacy with the minimal amount of side effects. All right, so I'm going to switch gears now to the PPAR drugs, the PPAR agonists. So how these drugs work is a little bit more difficult to explain, a little more complex. They do get absorbed and go to the liver. And when they get to the cells, what they do is they get into the cell and into the nucleus, and they bind to these response proteins that are attached to the DNA, okay? And in that way, they turn up or turn down the volume of how different genes are expressing different proteins. So, your DNA encodes the message for what proteins you're going to make. And this will just kind of adjust how much of those you make. Given the recent kind of COVID vaccine misinformation, I feel I should be clear and say that these drugs do not get into your DNA. They do not alter your DNA. They get completely metabolized and disappear from your body. But they are kind of adjusting that volume control on certain proteins. And the proteins that they change result in increase in bile acid metabolism. They help eliminate bile acids. They decrease bile acid production. They also decrease inflammation. And all of these mechanisms are probably relevant to decreasing itch in PBC. So bezafibrate is a PPAR agonist that is freely available in Europe and in Canada. And this is a phase 3 study from France showing you on the left the improvement in itch score in blue with the drug as compared to the placebo in red. So big difference in itch improvement. And then this led to another study in Europe, the Fitch study, which you see on the right, where they tested patients with all different kinds of liver disease. They had a subset of patients with PBC that you see there showing the almost 55% of patients had their itching dropped at least in half. As opposed to 13% on placebo. So pretty good anti-itch results. Another PPAR agonist that's in development is this seladelpar. You can see in the pretty picture there, that's the drug attaching to the green, attaching to the purple response element and the helical DNA below it. And in that study, they had 65 patients that were randomized to placebo and 128 on the 10 milligrams. And if you look at how many actually had moderate or severe itching, so greater than or equal to 4 out of 10, it was 23 patients in the placebo group and 49 patients on the seladelpar. And below in the graph, you could see what happened to their itching. The patients that were on the seladelpar in the lower light blue graph had a greater reduction in itch scores as compared to the people who were on placebo. And then another PPAR agonist that just came out with their phase 3 results is elafibranor. And they had 44 patients treated with elafibranor who had moderate to severe pruritus, and compared those to 22 who were treated with placebo. And you can see the elafibranor is the lower graph there with the lower itch scores. This study, they didn't actually meet statistical significance in this analysis, but then they had like some other measures where they did meet statistical analysis or significance, and so they're doing some kind of further analyses. So those are a lot of graphs and numbers, and I wanted to show you these pictures. Actually, I'm very excited to show this to you. Y'all are the first person to see these pictures. This is one of my patients. I showed you a picture of her foot in the beginning, who had really terrible itching all over, but especially on the bottom of her feet. And you can see where she's clawed them up. And then we enrolled her in a PPAR agonist trial, and this is what her feet looked like a few weeks after being on the drug. So the company that makes the drug hasn't even seen these pictures yet. All right, and then if all else fails, if the medications fail, there are other things that we can try. We can do plasmapheresis, which is almost like a dialysis where they take your blood out and filter it and put it back in you. We can do external biliary drainage, where they put a tube in your side that drains the bile out of your body into a little bag. And sometimes if it's really severe, we'll actually get exception points from the National Review Board to do a transplant, even in someone who doesn't have cirrhosis, just to treat the itching. So to summarize, itching is very common in PBC, although not as common as y'all seem to think. Y'all seem to think it's 100%, but it's about 75%. Eventually will affect 3 out of 4 persons. Doctors are unfortunately not good at addressing itch. So number 1, you all need to advocate for yourselves, but number 2, we need to do a much better job of educating physicians to address this in their clinics. And on that note, I'm going to put out some feelers. If there's anybody in the audience who feels they are willing to share their story about dealing with PBC itch, I'm putting together kind of a web-based video educational module about PBC itch, and we're looking for like a patient to kind of give their story, and you'll get reimbursed for it. So please come talk to me if you're willing to do that. Remember that there's a lot of non-prescription ways that you can manage the itch using light therapy, temperature modulation, over-the-counter sedatives such as antihistamines. There's a lot of prescription options out there to manage itch if you haven't tried them all. And there are 2 new classes of drugs that are in clinical trials that are really showing a lot of promise for PBC itch, the IBAT drugs and the PPAR drugs. So it's a really exciting time. So this is my optimistic Arizona landscape with a beautiful sunrise on the horizon. Thanks. Sorry.
No worries at all. Thank you for a good discussion. I think we may have some questions, so Naomi will be there with the microphone. Yeah, sorry about that. I have probably a couple here. Because one thing, too, I was just wondering, Dr. Vierling yesterday talked about IL-31 and kind of the whole idea of testing for itch. Is that something that you see as kind of a potential coming down the road?
As a diagnostic test for itch? You mean to delineate whether it's from PBC or not?
Yeah, and also help doctors, accept the thoughts.
Accept the thought that they're having itch?
Yeah.
So IL-31 was one of those things in the long list of chemicals that I had that's a putative thing, because it's been linked to chronic itch, not just in PBC though, it's also been linked to other forms of itch, like psoriasis and atopic dermatitis. So I don't know that it would be helpful to help you determine that the itching is from PBC versus something else. Okay. It's a cytokine, it's an inflammatory marker. It might be useful in sort of getting an objective grade of severity as opposed to just like, tell me what your itching is, 1 to 10. But we need to do those studies correlating the 1 to 10s with the IL-31 levels. Okay. One group has done it, but we need to do it more.
Okay, cool. Any specific questions you have yet?
I just have one. Am I on? Oh, there.
Yeah, you're on.
Um,
You're live.
So if you don't have the itch and you know, proceed on with your treatments and everything's going fine, what is the likelihood that, you know, it could show up? I mean, would it be a change in your URSO, you know, you know, the amount that you take or what?
Is that very common where someone will not have it and then develop it later down the road?
I mean, it happens, yeah. I mean, statistically, it's kind of the data that I showed you that 3 out of 4 people will eventually get it. You know, when I say eventually, not everybody has that at diagnosis or even before diagnosis. So there are some Japanese studies looking at kind of the asymptomatic PBC patient becoming symptomatic later down the road. Yeah, I can't give you a number of how likely it is that you're going to get it, but it might happen.
When I was at another group, I heard a woman talking about her itch increasing when she would have cookies and sweet food and stuff like that. Is there much around diet and kind of its influence, positive or negative?
Yeah, it's funny that you asked that because I think that that's a study that needs to be done. Has not been done. I think it would be great that the PBCers could maybe kind of get involved with that, because there are no studies looking at diet and how it affects PBC itch specifically. But I've certainly had patients tell me red meat makes me itch, or you know, this makes me itch, and so I think that needs to be studied.
Okay. And someone also mentioned in one of the discussions about UDC or URSO and basically it improving it. And then 2 years later, I talked to my hepatologist into increasing my URSO dose, and my itching stopped. So I guess I got worst itch about 2 years prior to diagnosis, starting on URSO, it improved greatly 2 years later.
I've heard that before too. I've heard URSO makes my itching worse, and I've heard URSO makes my itching better.
Okay.
If we take, you know, hundreds and hundreds and hundreds of people, you can see the net result is neither one. But for individual people, I've certainly heard one or the other.
Okay. And what about doxepin?
So doxepin is an antihistamine. I would say of the antihistamines, it's probably one of my favorites if you're going to use one for itching, just because the long period of action of it. It's also one of the problems with using antihistamines in PBC a lot of times is that they also are drying. So they cause dry mouth and dry eyes. I mean, they're supposed to dry you up, right? That's why they're used for congestion. So for people who have dry mouth and dry eyes already, sometimes that really makes it worse.
Gotcha.
And doxepin is a little bit better at not causing so much dry mouth.
Okay. Any thoughts as well around at WSLD, someone mentioned about PFIC and potentially a genetic marker or one gene being turned on for PFIC and PBC. Any thoughts around that?
Well, that's the holy grail, would be if we can find a single gene. But my cynicism, I don't think it's going to happen, because there have been a couple of groups now that have done what we call genome-wide association studies, where they sequence the entire genome, you know, beginning to end in a large group of patients to see if there's any consistent, you know, mutations from one to another, and they didn't come up with that single gene like they have in PFIC.
Okay, great. Any other questions in the crowd? No?
Everybody is just ready to hit the pool and have a margarita.
Well, get that, some of the team members are
They're already there.
getting the sun, and sounds like that has some potential help, right, with the sun?
Yeah, just don't get burned. That'll make it worse.
Oh,
Don't get
Sabrina.
burned.
Sabrina. Great. Well, we appreciate
Did you get burned already?
Yeah, yesterday, or a couple days ago.